Thanks everybody. My topic today, as Sherry said, is alternative financing for TB. And I would just say, if you take one thing away from what I'm about to say, let it be this, that the issue is not that TB needs alternative financing, the issue is that TB needs more financing. And I was almost a bit hesitant to use the term alternative finance. It was a little maybe broader than innovative finance, but for fear of suggesting that it means it should be an alternative or a replacement for existing funding streams. Because alternative financing, as we speak about it, needs to be a means to achieve additional financing overall. So when we look at alternative financing models and what they can do, I also want to be really clear about what they can't do. And what it is a way to achieve an additionality of financing through either new revenue streams or a way to incentivize or capture more existing development finance for TB and health, and I'll talk a little bit about both those things. But also what it is not. It is not an alternative to sustained and increased donor financing or domestic resource mobilization, and it is not, unfortunately, a silver bullet to close the financing gap. But again, done right, it can have an impact. There's sort of many estimates and definitions of how you look at innovative finance or alternative finance, but there was a July 2017 Lancet analysis that looked at innovative financing instruments, specific instruments, for global health from 2002 to 2015. And it found that innovative financing instruments accounted for only 2.3% of development assistance for health. Now, you can cut it various ways. You could argue about exactly how they did it, but it is true, given some of the considerations they had, it's a relatively small amount, and about 2.9% for the Global Fund, though, as you see, like for UnitAid, quite important, and interestingly for Gavi around some of the vaccine mechanisms. But again, aside from things like solidarity levies, the airline tax, and the potential for a European financial transaction tax, or a few other significant mechanisms, many of these innovative financing schemes are smaller scale. But I also think if we think creatively about what we mean by innovative strategies more broadly, I think we can also look at other interesting ways to capture existing development finance or expand the pool of it. And that could include innovative ways to crowd in more overall development finance, like World Bank concessional finance, or creating larger pools of low interest or grant finance by buying down commercial rate loans. And I'll say a little bit more about both of these, so kind of an expansive definition. I'm going to look at a few examples. It won't be across the board, but just some examples to illustrate. And none of the examples I share will be perfect. They may not be right for a number of countries, and they may or may not be something we should fully embrace for TB, but I think they'll provide some interesting lessons. And I think, again, maybe the most important thing when we look at kind of innovative or alternative financing is starting with criteria by which to make decisions or judge these instruments. And so I want to propose a few criteria. You may have others of your own in the discussion. But for me, the questions really need to be, first of all, does it result in additional money for TB? Second, does it prioritize or at least protect equity? Third, does it meet some minimum standard of do no harm? And does it ideally increase impact? So first on additionality. First question is, does a strategy actually bring in more money for tuberculosis and health? But if so, how do we ensure that that money is truly additional and not a replacement? Again, just to repeat what I said earlier, we can't use innovative financing as a way to, or an excuse to either reduce or even flatline really critical donor financing ODA, or to slow down the efforts around domestic resource mobilization. Because we're not at a point where we can sustain financing. If we sustain financing for TB, then we will fail at all our goals. We need to increase financing for TB. But again, done right, this can provide either new streams of financing to the development space or capture more development financing for health and TB. The second principle I would argue is equity, because the treatment gap is an equity issue. Achieving universal access, and what we're calling for now, is going to require a shift from a focus on overall coverage to a concentrated effort to reach the most vulnerable populations. Every year we're missing over 4 million people, as we've talked about, and many of those people are being either passively neglected or actively excluded. And additional funding should be targeting reaching them first. And it's both the right thing to do and also the only viable way to actually achieve the end of the epidemic. And just a few examples of kind of unintended consequences on equity. A number of innovative financing schemes, as people are aware of, use pay-for-performance or a results-based financing and aim for rapid results. There's lots of good things about results-based financing, but if it's not done right, they can actually skew resources away from the very poor and marginalized groups by actually incentivizing filling a quota quickly with the easier to reach. And the other thing I'd say is if financing mechanisms or schemes don't allow or facilitate funding for civil society and affected communities, whether it's a strictly a mechanism that only works with governments or one like results-based financing, that it's sometimes hard for civil society organizations to be actually front-load some of that money, then much of the work needed to build community systems, reach the most marginalized, and assure accountability won't happen. The third principle, which is a pretty basic kind of red line, is do no harm. So again, as some of the points I made before, don't skew resources away from the hardest to reach. Don't impose harmful policies that I think we've all agreed have negative consequences, like point-of-service user fees. Don't exclude civil society and communities from funding decisions. And then also, really importantly with some of these mechanisms, don't assess a country's debt stress and don't increase that or increase it to unsustainable levels. Don't make that situation worse. And there's probably more do no harms that you could all add in the discussion. And the last is really is impact. In some ways, this is the most straightforward, but we need to ensure that financing schemes aren't so convoluted that they don't actually deliver results, real impact for reaching people. We need to do more to track those, but we also need to ensure both concrete impact but also equitable outcomes as a part of what we see as impact. So with those principles in mind, I'm just going to very kind of briefly go through a couple of examples of mechanisms and talk a little bit about after how those existing models stack up. So one that many folks are quite familiar with, which is UnitAid, which is funded largely, not exclusively, by the airline ticket levy that was launched in 2006 in 13 countries. Its goal is to catalyze equitable access to better products, innovation, access, scale, value for money. It is focused on TB, HIV, malaria, plus opportunistic infections and some cross-cutting work. But again, a model of where you actually created a new stream of financing, which over 10 years has provided something like $2.5 billion through UnitAid, and an interesting mix of countries, both traditional donor countries and other countries that are funders of this. So I think an important model, and also points to the potential for things like a larger scale financial transaction tax, which is certainly being discussed among EU members. Other people in the room can speak more to the political challenges of that, but the potential scale of resources that could be achieved in the tens of billions, and even capturing a small portion of that for health, could be hugely important in terms of the kind of scale of resources that are possible in this space. Another smaller but kind of, I think, important example is the debt to health mechanism, where creditors agree to relinquish debt payments if those repayments are part or all of those repayments are paid by the country to the Global Fund for the country's own AIDS, TB, malaria programs. And that has, at this point, mobilized something like $200 million between what's already been spent and what's in the pipeline. I think, and countries and beneficiaries include Indonesia, Pakistan, Cote d'Ivoire, Ethiopia, Cameroon, DRC, with creditors including Germany, Australia, and Spain. And I think, the important thing here is it's a modest amount of resource, but it's also moving us in the right direction of reduced debt as well, and with those resources flowing through the Global Fund with the sort of positive outcomes that we get there. Now I want to talk about a few potential mechanisms to crowd in more development finance for TB and for health more broadly. And I particularly look to the World Bank because there's a lot of money there. And I don't know if people are tracking it, but the last replenishment of the World Bank's low-interest lending arm, IDA, for IDA 18, which we're just about in the middle of now, was $75 billion, a 44% increase over the previous IDA. And the World Bank on its own, at the highest levels of the bank, has launched this human capital project, which says public sector resources should be prioritized for only what the public sector can do, and private sector resources should be used for those things that the private sector can do, and so more investment in human capital, health, education, nutrition, social protection needs to be a priority for the bank and for countries. So I ask us to sort of think about what could even a proportional increase in IDA health investment buy you could see an additional potentially $2 billion. I'm not saying we'll get there in IDA 18, but you could, if you look at the baseline of the last IDA and the 44% increase, that's the kind of scale that you could get. And for me, the question is also, countries will use every single dollar that they get of this money because it is really cheap money. The question is not whether they will spend it or not, it's whether they will spend it on an airport, or whether they will spend it on health and education and other sort of human sector priorities and pro-poor priorities, ideally. I'm just going to mention two mechanisms that actually are helping leverage World Bank money for health areas. And one that folks may have heard a good bit about is the Global Financing Facility for Every Woman, Every Child, that was created and funded by a group of donors to increase the impact, scale, and sustainability of reproductive, maternal, newborn, child, and adolescent health and nutrition. And with over $1 billion in a trust fund that is used actually in small chunks to incentivize countries to then both increase some of their domestic resource mobilization, but particularly to use more of their IDA money as well for investments in reproductive, maternal, newborn, and child health. The data that we have now, though there will be new data coming out this Tuesday that will be even higher, is over $2.7 billion in IDA and other bank lending against $405 million invested in the trust fund. So that's a ratio of 7-to-1 of bank funding to this trust fund. That doesn't mean that you're absolutely leveraging 7-to-1 in resources, because the baseline was not zero. Countries were taking some money before, but we've done our own analysis kind of looking at that. It looks like in the majority of countries, you are seeing a significant uptick in the use of this World Bank money for health purposes, and reproductive, maternal, newborn, and child health purposes. So a model for that. Another one that's just interesting, smaller but quite interesting, is Power of Nutrition, also housed at the bank. Again, with a chunk of money that came from a number of public and private donors, it actually is trying to get other smaller funders, again, public and private, to put some money into nutrition-focused programs, and then it guarantees through a trust fund that will be doubled. And then either working with the World Bank or working with UNICEF, with matching funds from them, it's doubled again. So it both incentivizes some new donors to come into the space. It then uses a trust fund to expand that, and then it links to both the World Bank's funding or UNICEF's funding to, again, have some nutrition-focused areas. So something to sort of look at, again, as a mechanism for how you could do this. The last one that I want to focus on is just the issue of blended finance, which is essentially a mixture of grant funding and non-grant funding, equity or debt, to fund a particular project, intervention, or disease program. And one of the ways that this can be done is what they call Buydowns, which is essentially using a portion of grant funding to buy down a commercial interest rate loan down to either a much more concessional rate or even to a grant level, so that it increases the pool of financing that's available for particularly some middle-income countries that may not have as much access to low interest rate lending. And the Global Fund, in looking at this, if it were to provide a small amount of its funding to buy down, for example, a World Bank loan, said on average you would get a 5-to-1 ratio. So for instance, $10 million could buy down 5 times that amount, $50 million worth of financing, but it's also up to a 10-to-1 leverage depending on kind of where the country sits economically. And I won't go into the details, but there have been examples from the last decade where this was done for polio in Nigeria and Pakistan. It's done on a small scale for the Global Financing Facility in Guatemala with a very nutrition-focused program, and then it's being considered at some scale between the Global Fund and the World Bank for a big buy-down for tuberculosis funding for India, which has set some of the most ambitious goals in the world for reducing its TB and ending the epidemic by 2025. And I think what's interesting, it has the potential to create more low-interest or grant financing, but also with that targeted in a very specific way to high-priority areas. And I guess I'll just kind of end by saying, moving forward, like I do think that innovative or alternative financing has real opportunities to achieve some scale and also to achieve some sustainable and valuable streams of financing. I would say we should return to principles always. Does it grow the total resources? Does it ensure equity? Does it prevent harm? Does it increase impact? It's also very clear to me that we need resources from all sides. And again, this is not a substitute for other financing, but an addition or adjunct. And I just want to say, I didn't actually hear anybody say it today that money is not the problem that TB has, but if anybody does tell you that, just remember this quote from US poet Ogden Nash, that certainly there are things in life that money can't buy, but it's very funny. Did you ever try buying them without money? And I think that's the same. More money does not guarantee impact for TB, but without more resources, we will not achieve all the things we need to achieve. Thanks a lot. Thank you.